Question 1. Obstetric emergencies. Shoulder dystocia. A laboring patient is at full dilation and begins pushing. After the head delivers, the fetal shoulders fail to pass through the birth canal. The obstetric provider recognizes shoulder dystocia and calls for immediate assistance. As the nurse, what is the most appropriate first action in managing this emergency? A. Apply fundal pressure to help dislodge the fetal shoulder. B. Instruct the patient to push harder while providing perineal support. C. Perform Macrobert's maneuver and apply suprapubic pressure. D. Immediately prepare the patient for an emergency cesarean section. Answer. C. Perform Macrobert's maneuver and apply suprapubic pressure. Explanation. Shoulder dystocia is a life-threatening obstetric emergency in which the fetal shoulders become impacted behind the maternal pubic symphysis after the head has delivered. The first-line intervention is the Macrobert's maneuver, which involves hyperflexing the maternal thighs against the abdomen to widen the pelvic outlet. Suprapubic pressure is applied to attempt to rotate and dislocate the anterior fetal shoulder. Incorrect answers. A. Apply fundal pressure. This is contraindicated because it can worsen impaction and increase the risk of uterine rupture. B. Instruct the patient to push harder. This will not resolve the obstruction and may increase fetal distress. D. Prepare for an emergency cesarean section. While cesarean may be necessary if maneuvers fail, immediate vaginal maneuvers are the first step in management. Relevant guidelines. American College of Obstetricians and Gynecologists ACOG shoulder dystocia guidelines recommend Macrobert's maneuver and suprapubic pressure as first-line interventions. The help air mnemonic H. Call for help. E. Evaluate for epiciotomy L. Legs. Macrobert's P. Suprapubic pressure E. Enter maneuvers R. Remove posterior arm R. Roll patient to hands and knees. Guide systematic management. Question 2. Neonatal complications. Neonatal sepsis of full-term newborn develops poor feeding, lethargy, temperature instability, hypothermia, and tachypnea within the first 24 hours of life. As the neonatal nurse, you suspect neonatal sepsis. Which of the following is the most appropriate initial nursing intervention? A. Administer broad-spectrum antibiotics immediately without laboratory confirmation. B. Obtain blood, urine, and cerebrospinal fluid cultures before starting antibiotics. C. Monitor vital signs and wait for more definitive signs before alerting the provider. D. Encourage more frequent feedings to counteract lethargy and poor feeding. Answer. B. Obtain blood, urine, and cerebrospinal fluid cultures before starting antibiotics. Explanation. Neonatal sepsis is a medical emergency that requires early recognition and prompt initiation of antibiotics, but cultures should always be obtained first to guide therapy. Blood, urine, and cerebrospinal fluid (CSF) cultures help identify the causative organism and ensure appropriate antibiotic selection. Incorrect answers. Administer broad-spectrum antibiotics immediately without laboratory confirmation. While antibiotics should be started as soon as possible, obtaining cultures first is crucial for targeted treatment. C. Monitor vital signs and wait for more definitive signs. Delaying intervention can lead to rapid deterioration and increased mortality risk. D. Encourage more frequent feedings. While feeding support is important, it does not address underlying infection and sepsis progression. Relevant guidelines. The Centers for Disease Control and Prevention (CDC) and the Neonatal Sepsis Task Force recommend early recognition, culture collection, and prompt initiation of antibiotics in suspected sepsis cases. First-line antibiotics typically include ampicillin and gentamicin until culture results are available. Question 3. Scenario-based. Postpartum depression and mood disorders. Jessica, a 32-year-old first-time mother, comes to the postpartum clinic for her 6-week follow-up. She reports feeling overwhelmed, exhausted, and unable to bond with her baby. She states, "I sometimes wonder if my baby would be better off without me." She denies any specific plan to harm herself or her child. As her nurse, what is the most appropriate initial action? A. Reassure her that postpartum mood changes are normal and schedule routine follow-up in 4 weeks. B. Perform thorough assessment using the Edinburgh Postnatal Depression Scale (EPS) and notify the healthcare provider. C. Encourage her to join new mother support group and practice relaxation techniques. D. Advise her to ask family members for more help and ensure she gets more sleep. Answer. B. Perform a thorough assessment using the Edinburgh Postnatal Depression Scale (EPS) and notify the healthcare provider. Explanation. Jessica's symptoms are concerning for postpartum depression, PPD, serious mental health condition that can affect maternal-infant bonding and increase the risk of suicide. The Edinburgh Postnatal Depression Scale (EDS) is a validated screening tool to assess the severity of symptoms. Immediate evaluation by health provider is necessary to determine the need for psychotherapy, medication, e.g. asterisk or further intervention. Incorrect answers: A. Reassure her and schedule follow-up in 4 weeks. Delayed follow-up is inappropriate for patient expressing thoughts of worthlessness or distress. C. Encourage joining support group. While social support is beneficial, it is not substitute for professional evaluation and potential treatment. D. Advise her to ask for more help. While adequate rest and family support can help, they do not. The core mental health issue requiring medical intervention. Relevant guidelines. The American Psychiatric Association, APA, and American College of Obstetricians and Gynecologists, ACOG, recommend screening all postpartum women for depression at least once within the first 12 weeks. Postpartum PPD treatment options include cognitive behavioral therapy (CBT), antidepressants, SRS such as sertraline, and in severe hospitalization. Question 4. Obstetric nursing. Intrapartum care. 35-year-old gravid 3 para 2 woman at 41 weeks of gestation is admitted to the labor and delivery unit for induction of labor. Her medical history includes gestational hypertension managed with labetalol. The provider orders oxytocin for labor induction. After several hours, the nurse notes the following on the fetal heart monitor: repetitive late decelerations, minimal fetal heart rate variability, and uterine contractions occurring every 90 seconds. The patient is complaining of persistent uterine pain and pressure. What is the most appropriate initial nursing intervention? A. Discontinue oxytocin, administer oxygen via face mask, and reposition the patient to her left side. B. Increase the oxytocin infusion rate and encourage the patient to bear down to expedite delivery. C. Continue monitoring and notify the provider only if fetal bradycardia develops. D. Prepare the patient for an immediate cesarean delivery without further interventions. Answer: A. Discontinue oxytocin, administer oxygen via face mask, and reposition the patient to her left side. Explanation: the patient is exhibiting signs of uterine tachysystole, excessive uterine contractions, and fetal distress, late decelerations, and minimal variability, which may indicate uteroplacental insufficiency. Oxytocin should be discontinued immediately to reduce contractions, and the patient should be repositioned to improve blood flow to the placenta. Oxygen should be administered to increase fetal oxygenation. Option B is incorrect because increasing oxytocin would worsen uterine tachysystole and fetal distress. Option C is incorrect because fetal distress requires immediate intervention rather than waiting for bradycardia. Option D is incorrect because an emergency cesarean may not be necessary if intrauterine resuscitative measures improve fetal status. Relevant guidelines. According to the American College of Obstetricians and Gynecologists, ACOG, uterine tachysystole with fetal distress warrants immediate discontinuation of oxytocin, repositioning, oxygen administration, and intravenous fluid bolus. Question 5. Gynecologic nursing. Common gynecologic disorders. 29-year-old woman presents to the clinic with chronic pelvic pain, dysmenorrhea, and dyspareunia. She has had difficulty conceiving for the past 2 years. Her menstrual cycles are regular but accompanied by severe pain that does not respond well to NSAIDs. Transvaginal ultrasound reveals the presence of ovarian endometriomas. Based on this presentation, which following is the most likely diagnosis: A. Polycystic ovary syndrome, PCOS. B. Endometriosis. C. Pelvic inflammatory disease, PID. D. Uterine fibroids. Answer: B. Endometriosis. Explanation: endometriosis is characterized by chronic pelvic pain, dysmenorrhea, painful menstruation, dyspareunia, painful intercourse, and infertility. The presence of ovarian endometriomas, choplet cysts, on ultrasound strongly supports the diagnosis. Option A is incorrect because PCOS is associated with irregular menstrual cycles, hyperandrogenism, and multiple small ovarian cysts, rather than painful periods. Option C is incorrect because PID typically presents with fever, cervical motion tenderness, and purulent vaginal discharge, which are not mentioned here. Option D is incorrect because uterine fibroids cause heavy menstrual bleeding and pressure symptoms rather than cyclical pelvic pain and infertility. Relevant guidelines. The American Society for Reproductive Medicine (ASRM) states that laparoscopy is the gold standard for diagnosing endometriosis, and treatment includes NSAIDs, hormonal therapy, erogenous progestins or surgical excision. Question 6. Neonatal nursing. Neonatal complications and conditions. Preterm neonate born at 30 weeks gestation is admitted to the neonatal intensive care unit (NICU). Within the first 48 hours of life, the baby develops increased oxygen requirements, nasal flaring, grunting, and intercostal retractions. Chest X-ray reveals diffuse reticular granular pattern with air bronchograms. What is the most likely diagnosis? What is the primary treatment? A. Neonatal sepsis, broad-spectrum antibiotics. B. Transient tachypnea of the newborn, TTN, supplemental oxygen. C. Respiratory distress syndrome, RDS, exogenous surfactant administration. D. Meconium aspiration syndrome, mechanical ventilation. Answer C. Respiratory distress syndrome, RDS, exogenous surfactant administration. Explanation. RDS is caused by surfactant deficiency in preterm infants leading to alveolar collapse. Symptoms include grunting, nasal flaring, retractions, and increasing oxygen needs. The characteristic chest X-ray finding is a diffuse reticular granular pattern, ground glass appearance with air bronchograms. Exogenous surfactant therapy and pressure ventilation are the mainstays of treatment. Option A is incorrect because neonatal sepsis may present with respiratory distress, but it would also include temperature instability and lethargy. Option B is incorrect because TTN typically resolves within 24 hours and does not have the classic chest X-ray findings of RDS. Option D is incorrect because meconium aspiration occurs in term or post-term infants and presents with coarse patchy infiltrates on X-ray rather than a ground glass appearance. Relevant guidelines. The American Academy of Pediatrics recommends antenatal corticosteroids for pregnant women at risk of preterm delivery to reduce the risk of RDS. Question 7. Scenario-based. Professional issues and ethical considerations. Nurse Julia is working in the labor and delivery unit when she receives request from law enforcement officer. The officer asks for medical records of recent patient who gave birth and was suspected of substance abuse during pregnancy. The officer states that they need the records for an ongoing criminal investigation. The patient has not given consent to release her information. What is the most appropriate response by Nurse Julia? A. Provide the medical records to the officer as law enforcement investigations take precedence over patient confidentiality. B. Decline the request and inform the officer that patient confidentiality is protected under HIPAA unless court order or patient consent is provided. C. Contact the hospital's risk management department before making decision. D. Provide only the newborn's medical records, as the mother's information is protected but baby's is not. Answer. B. Decline the request and inform the officer that patient confidentiality is protected under HIPAA unless a court order or patient consent is provided. Explanation. The Health Insurance Portability and Accountability Act (HIPAA) protects patient health information, including medical records. Law enforcement cannot access patient records without a court order, subpoena, or patient consent. Option A is incorrect because HIPAA protections still apply even in criminal investigations. Option C is incorrect because while risk management can be consulted, the law clearly prohibits release of information without proper legal authorization. Option D is incorrect because newborn medical records are also protected by HIPAA unless a legal guardian consents. Relevant guidelines. EU.'s Department of Health and Human Service (HHS) states that patient information can only be disclosed to law enforcement under specific legal circumstances, such as the court order. Question 8. Obstetric nursing. Prenatal care. 26-year-old woman at 32 weeks gestation presents to the clinic for her routine prenatal visit. She reports occasional headaches, blurry vision, and swelling in her hands and feet, especially in the evening. Her blood pressure is 150/95 mm Hg and her urine dipstick shows 1 protein. Her obstetric history includes previous pregnancy complicated gestational hypertension. What is the most likely diagnosis and the appropriate management for this patient? A. Preeclampsia. Initiate bed rest and monitor blood pressure closely. B. Chronic hypertension. Start antihypertensive medication and schedule frequent follow-up visits. C. Gestational hypertension. Begin daily blood pressure monitoring and close observation. D. Preeclampsia with severe features. Initiate magnesium sulfate and prepare for delivery. Answer. C. Gestational hypertension. Begin daily blood pressure monitoring and close observation. Explanation. The patient presents with elevated blood pressure and proteinuria after 20 weeks of gestation, indicative of gestational hypertension. In the absence of severe features like thrombocytopenia or elevated liver enzymes, the patient should be closely monitored with weekly blood pressure checks and urine dipstick testing for protein. Option A is incorrect because preeclampsia involves additional severe symptoms like hyperreflexia or elevated liver enzymes and is not yet confirmed. Option B is incorrect as chronic hypertension is present before pregnancy and requires long-term medication management. Option D is incorrect because preeclampsia with severe features would require more immediate intervention, including magnesium sulfate for seizure prevention and possible early delivery, which is not indicated here. Relevant guidelines. According to ACOG, gestational hypertension requires close monitoring, with delivery indicated at 37 weeks or earlier if severe features develop. Question 9. Gynecologic nursing. Contraception. 34-year-old woman with history of migraines with aura is seeking advice on contraceptive options. She currently does not wish to conceive but is concerned about the side effects of hormonal contraception. Which of the following contraceptive methods would be most appropriate for this patient? A. Combined oral contraceptives, COX. B. Levonorgestrel intrauterine device, IUD. C. Depomedroxyprogesterone acetate, DMPA. D. Progestin-only pills. Answer: B. Levonorgestrel intrauterine device, IUD. Explanation: women with a history of migraines with aura are contraindicated from using combined hormonal contraceptives, COX, due to the increased risk of stroke. The levonorgestrel IUD is a non-systemic method and can effectively prevent pregnancy with minimal hormonal effects. Option A is incorrect because combined oral contraceptives are contraindicated in women with migraines with aura. Option C is incorrect because depomedroxyprogesterone acetate, DMPA, is a hormonal method that could potentially exacerbate side effects in this patient. Option D is incorrect because although progestin-only pills are considered safer for migraine sufferers, the IUD offers better long-term efficacy and convenience. Relevant guidelines. According to ACOG, IUDs are recommended for women who cannot use estrogen-based contraceptives, particularly those with a history of migraines with aura. Question 10. Neonatal nursing. Neonatal sepsis. 24-hour-old neonate born at 38 weeks gestation via cesarean section is being evaluated for signs of neonatal sepsis. The baby has temperature of 100.4 deg, 38 deg, irritability, poor feeding, and lethargy. The white blood cell count is elevated and blood cultures are pending. What is the most appropriate next step in the management of this neo? A. Start broad-spectrum antibiotics and notify the neonatologist. B. Reassure the parents that this is likely benign self-limiting condition. C. Conduct additional testing for viral infections before starting antibiotics. D. Wait for the results of the blood cultures before initiating treatment. Answer: A. Start broad-spectrum antibiotics and notify the neonatologist. Explanation: neonatal sepsis is a medical emergency and prompt initiation of broad-spectrum antibiotics is critical while awaiting culture results. Early treatment improves outcomes in neonates with suspected sepsis. Option B is incorrect because neonatal sepsis is a serious condition that requires immediate attention and cannot be dismissed as self-limiting. Option C is incorrect because sepsis must be treated with antibiotics immediately while waiting for results of viral tests or blood cultures. Option D is incorrect because delaying treatment can result in worsened outcomes, including organ failure and death. Relevant guidelines. According to the CDC, antibiotics should be started empirically in any neonate showing signs of infection, particularly in the first few days of life. Question 11. Neonatal nursing. Respiratory distress. Full-term neonate is admitted to the NICU with respiratory distress shortly after birth. The baby is grunting, tachypneic, and exhibiting intercostal retractions. The chest X-ray shows hyperinflated lung with flattened diaphragms. Given these findings, what is the most likely diagnosis? A. Respiratory distress syndrome, RDS. B. Pneumothorax. C. Transient tachypnea of the newborn, TTN. D. Meconium aspiration syndrome, MAS. Answer: C. Transient tachypnea of the newborn, TTN. Explanation: the signs of tachypnea, grunting, and intercostal retractions, along with a chest X-ray showing hyperinflation and flattened diaphragms, are consistent with transient tachypnea of the newborn, TTN. This condition, also known as wet lung, is often seen in full-term or late preterm neonates and is due to delayed clearance of lung fluid after birth. Option A is incorrect because RDS typically presents in preterm infants and shows ground glass appearance on chest X-ray, not hyperinflation. Option B is incorrect because pneumothorax would present with unilateral lung collapse and shifted mediastinum on chest X-ray, which is not seen here. Option D is incorrect because meconium aspiration syndrome presents with more severe respiratory distress and bilateral infiltrates on chest X-ray, along with tachypnea and cyanosis. Relevant guidelines. OP guidelines recommend supportive care for TTN, which typically resolves within 72 hours without long-term complications. Question 12. Obstetric nursing. Labor complications. 28-year-old woman at 40 weeks gestation presents to the labor and delivery unit with irregular contractions. Upon examination, the cervix is 4 centimeters dilated, 80% effaced, and the fetal heart rate is 160 bpm with good variability. However, after several hours of labor, the contractions become more frequent but less effective, and the dilation remains at 4 centimeters. The provider diagnoses labor arrest. What is the most appropriate next step? A. Perform an immediate cesarean delivery. B. Augment labor with oxytocin and reassess in several hours. C. Begin epidural analgesia and await spontaneous progress. D. Discontinue oxytocin and monitor the patient's progress for the next 24 hours. Answer: B. Augment labor with oxytocin and reassess in several hours. Explanation: labor arrest failure to progress at 4 centimeters typically requires labor augmentation with oxytocin if there are no signs of fetal distress or other contraindications. If labor does not progress, more definitive measures may be required, but oxytocin is often the first-line approach. Option A is incorrect because cesarean delivery is typically not indicated unless fetal distress or other complications arise. Option C is incorrect because while epidural analgesia may improve comfort, it does not address the labor arrest itself. Option D is incorrect because monitoring for 24 hours without intervention could lead to maternal or fetal complications. Relevant guidelines. According to ACOG, oxytocin augmentation is appropriate for labor arrest if the cervix is at least 4 centimeters dilated, the membranes are ruptured, and the fetus is well positioned. Question 13. Gynecologic nursing. Cancer screening. 55-year-old woman presents for her routine checkup. She has history of irregular menstrual cycles but is postmenopausal for 3 years. She asks about the benefits of routine screening for cervical cancer. Based on current guidelines, what is the most appropriate recommendation for this patient? A. Pap smear every 3 years until age 65. B. Pap smear every 5 years with HPV testing until age 65. C. Routine screening is no longer necessary after menopause. D. Annual mammography and breast exams should be prioritized over cervical screening. Answer: B. Pap smear every 5 years with HPV testing until age 65. Explanation: ACOG and USPS recommend Pap smear screening every 5 years with HPV testing for women aged 30 to 65. Screening can be discontinued after age 65 if there is a history of normal screenings and no high-risk factors. Option A is incorrect because current guidelines recommend screening every 5 years, not 3. Option C is incorrect because routine screening is still necessary for women in this age group who have not been screened recently. Option D is incorrect because cervical cancer screening remains an important part of preventive care, although mammography is equally important. Relevant guidelines. According to the USPS, cervical cancer screening can stop at age 65 for women with a history of normal Pap smears and no cervical cancer risk factors. Question 14. Obstetric nursing. Postpartum care. 30-year-old woman, GP, delivers healthy infant vaginally without complications. On postpartum day 2, she reports severe perineal pain, difficulty urinating, and blood-tinged urine. She has no fever, but vital signs are within normal limits. Upon examination, you find slight swelling and bruising in the perineal area. What is the most likely cause of her symptoms, and what is the most appropriate management strategy? A. Perineal hematoma. Apply ice to the perineum and monitor for further signs of infection. B. Urinary retention due to bladder distension. Catheterize the patient immediately. C. Postpartum urinary tract infection, UT. Administer antibiotics and monitor for fever. D. Postpartum hemorrhage. Immediate uterine massage and consider blood transfusion. Answer A. Perineal hematoma. Apply ice to the perineum and monitor for further signs of infection. Explanation: the symptoms of severe perineal pain, difficulty urinating, and blood-tinged urine with no fever suggest the presence of A perineal hematoma, which can occur after vaginal delivery due to trauma to blood vessels in the perineum. Ice should be applied to the affected area to reduce swelling and discomfort, and the patient should be monitored for signs of further bleeding or infection. Option B is incorrect because urinary retention, while common postpartum, would likely be accompanied by more noticeable distension and a palpable bladder. Option C is incorrect because the absence of fever and systemic signs suggests a UT is unlikely. Option D is incorrect because the patient does not have signs of hemorrhage, such as heavy bleeding or hypotension. Relevant guidelines, according to COG, perineal hematomas are managed conservatively unless they grow large or show signs of infection. Question 15. Gynecologic nursing. Pelvic inflammatory disease. 22-year-old woman presents to the clinic with pelvic pain, vaginal discharge, and fever. She has history of multiple sexual partners and inconsistent use of contraception. Physical examination reveals tenderness in the lower abdomen and cervical motion tenderness. The patient is diagnosed with pelvic inflammatory disease (PID). What is the most appropriate initial treatment for this patient? A. Oral antibiotics only and discharge home with follow-up. B. Intravenous antibiotics followed by oral antibiotics after improvement. C. Surgical drainage of the infected pelvic abscess. D. Administer high-dose estrogen therapy to suppress infection. Answer: B. Intravenous antibiotics followed by oral antibiotics after improvement. Explanation: it is treated with intravenous antibiotics initially for severe cases, especially if the patient is febrile or has severe symptoms. After the patient improves, they can be switched to oral antibiotics. The goal is to treat the infection and prevent long-term complications such as infertility. Option A is incorrect because oral antibiotics alone are not sufficient for more severe or complicated PID cases. Option C is incorrect because surgical drainage is reserved for abscesses or other complications of PID, not the standard initial treatment. Option D is incorrect because high-dose estrogen therapy is not used in the management of PID. Estrogen may actually increase the risk of PID. Relevant guidelines: CDC guidelines recommend Roman antibiotics for moderate to severe PID and a 14-day regimen with both ceftriaxone and doxycycline. Question 16. Neonatal nursing. Jaundice. 2-day-old neonate is brought to the pediatric clinic for follow-up visit. The baby was born at term and had an unremarkable birth history. The mother reports that the baby's skin appears slightly yellow, especially on the face and torso. The infant is feeding well and is otherwise alert. The bilirubin level is 12 mdl. What is the most appropriate management for this neonate? A. Begin phototherapy immediately and monitor bilirubin levels. B. Monitor bilirubin levels and provide adequate hydration. Follow up in 24 hours. C. Perform direct Coombs test to rule out hemolytic disease. D. Begin oral vitamin K supplementation to address possible vitamin deficiency. Answer: B. Monitor bilirubin levels and provide adequate hydration. Follow up in 24 hours. Explanation: physiological jaundice is common in the first few days of life, and the bilirubin level of 12 mdl is typically manageable with monitoring and proper hydration. The yellowing of the skin suggests mild, unconjugated hyperbilirubinemia, which usually resolves on its own. Regular follow-up in 24 hours. Appropriate to ensure the bilirubin does not rise to dangerous levels. Option A is incorrect because phototherapy is generally initiated for bilirubin levels above 15 ddl or for levels of 12 mdl. Option C is incorrect because the absence of other signs of hemolysis, such as anemia or positive family history, makes hemolytic disease unlikely. Option D is incorrect because vitamin K is not used for jaundice. It is administered to prevent hemorrhagic disease in newborns but is unrelated to jaundice. Relevant guidelines: according to the physiological jaundice typically resolves within the first 2 weeks of life and does not require intervention unless bilirubin levels exceed critical thresholds. Question 17. Obstetric nursing. Postpartum hemorrhage. 28-year-old woman delivers healthy infant via vaginal delivery. The placenta is expelled spontaneously, but after delivery she begins to experience heavy bleeding greater than 500 ml. Her uterus is boggy on palpation and uterine massage does not stop the bleeding. What is the most likely cause of the hemorrhage and what is the initial intervention? A. Uterine atony. Begin oxytocin infusion and apply uterine massage. B. Retained placenta. Perform manual removal of the placenta. C. Cervical lacerations. Repair lacerations in the operating room. D. Coagulopathy. Administer fresh frozen plasma and monitor for further bleeding. Answer: A. Uterine atony. Begin oxytocin infusion and apply uterine massage. Explanation: the most common cause of postpartum hemorrhage is uterine atony, where the uterus fails to contract adequately after delivery. The initial management involves uterine massage and oxytocin infusion to promote uterine contractions and reduce bleeding. Option B is incorrect because retained placenta typically presents with failure to deliver the placenta or expulsion of parts of the placenta, which is not indicated here. Option C is incorrect because cervical lacerations are usually accompanied by bright red bleeding that does not respond to uterine massage, unlike uterine atony. Option D is incorrect because coagulopathy is a less common cause of hemorrhage and would be diagnosed based on abnormal lab tests, which are not indicated in this scenario. Relevant guidelines, according to ACOG, oxytocin should be administered immediately if uterine atony is suspected to promote uterine contraction and minimize blood loss. Question 18. Gynecologic nursing. Menopause. 50-year-old woman presents with symptoms of hot flashes, night sweats, and irritability. Her menstrual cycles have become irregular over the past year, and she has family history of osteoporosis. She is concerned about the potential for bone loss during menopause. Which of the following interventions is most appropriate for this patient? A. Start combined hormone replacement (HRT) to address hot flashes and reduce osteoporosis risk. B. Advise calcium and vitamin D supplementation and monitor bone density. C. Prescribe selective estrogen receptor modulators (SERMs) to prevent bone loss. D. Initiate bisphosphonate therapy to prevent osteoporosis immediately. Answer: B. Advise calcium and vitamin D supplementation and monitor bone density. Explanation: for a woman with early menopause symptoms and a family history of osteoporosis, calcium and vitamin D supplementation should be recommended along with monitoring bone density. Starting HRT may also be considered but must be done cautiously, weighing the risks and benefits. Option A is incorrect because where HRT may help with menopause symptoms, it carries risks such as breast cancer and cardiovascular disease that should be discussed with the patient. Option C is incorrect because SERMs are not the first-line treatment for menopause-related symptoms and osteoporosis prevention. Option D is incorrect because bisphosphonates are generally reserved for established osteoporosis rather than initial prevention. Relevant guidelines, according to the North American Menopause Society, calcium and vitamin D supplementation, along with bone density screening, are critical for women at risk for osteoporosis during menopause. Question 19. Neonatal nursing. Hypoglycemia. 24-hour-old neonate is found to have blood glucose level of 45 mdL. The infant was born via cesarean section to mother with gestational diabetes. The neonate is symptomatic, showing signs of irritability, jitteriness, and poor feeding. What is the most appropriate management for this neonate? A. Feed the neonate and recheck the glucose in 30 minutes. B. Start an intravenous glucose infusion immediately. C. Administer oral dextrose gel and monitor glucose levels. D. No immediate treatment is necessary as glucose levels are within normal range. Answer: A. Feed the neonate and recheck the glucose in 30 minutes. Explanation: in neonatal hypoglycemia, feeding the infant with breast milk or formula is the first-line intervention. The neonate should be re-evaluated after 30 minutes to ensure glucose levels return to normal. Option B is incorrect because intravenous glucose is typically reserved for more severe hypoglycemia or if the infant cannot feed orally. Option C is incorrect because oral dextrose gel is an alternative option for neonates who do not respond to initial feeding but is not the first step in this case. Option D is incorrect because a glucose level of 45 mdL is low and treatment is necessary to prevent complications. Relevant guidelines. According to OP guidelines, early feeding is crucial in preventing the progression of hypoglycemia in neonates, especially those at risk, such as infants born to mothers with gestational diabetes. Question 20. Obstetric nursing. Labor pain management. 29-year-old woman in active labor at 5 centimeters dilation requests an epidural for pain management. She has no significant medical history and is otherwise healthy. After thorough assessment, you prepare for the epidural placement. What is the most important consideration prior to administering the epidural anesthesia? A. Confirm that the patient has adequate hydration to avoid hypotension. B. Monitor fetal heart rate for signs of distress. C. Ensure that the patient has clear liquid diet for the last 6 hours. D. Start oxytocin immediately after the epidural to augment labor. Answer: A. Confirm that the patient has adequate hydration to avoid hypotension. Explanation. Before administering an epidural, it is crucial to ensure that the patient is adequately hydrated. Epidural anesthesia can cause hypotension, particularly in the first few minutes after administration, due to the blockade of sympathetic nerves that control vascular tone. To mitigate this risk, it is standard practice to give the patient an intravenous Romainoid bolus before the epidural placement to improve circulatory volume and reduce the likelihood of hypotension. Option B is incorrect because while fetal heart rate monitoring is essential throughout labor, it is not the primary concern directly before administering an epidural unless the patient has a risk for fetal distress. Hydration is the immediate priority. Option C is incorrect because a clear liquid diet within the last 6 hours is not a requirement for epidural anesthesia. This is more relevant for general anesthesia where a full stomach could increase the risk of aspiration. Option D is incorrect because oxytocin is not administered immediately after the epidural unless labor is not progressing adequately. The focus before epidural administration is primarily on preparing the patient and minimizing hypotension. Relevant guidelines. According to ACOG, hydration is critical prior to epidural placement to prevent complications related to hypotension. Intravenous fluids are typically administered in the form of an LR, lactated Rinner's bolus. Question 21. Gynecologic nursing. Endometriosis. 34-year-old woman presents with chronic pelvic pain, dysmenorrhea, and dyspareunia, painful intercourse. She has been trying to conceive for 6 months without success. Upon examination, you suspect that she may have endometriosis. What is the gold standard for diagnosing this condition? A. Transvaginal ultrasound to assess for endometrial cysts. B. A laparoscopy with biopsy of suspected lesions. C. MRI of the pelvis to confirm the extent of the disease. D. Hysterosalpingogram HSG to evaluate fallopian tube patency. Answer. B. Laparoscopy with biopsy of suspected lesions. Explanation. The gold standard for diagnosing endometriosis is laparoscopy with the biopsy of any suspected lesions. Laparoscopy allows direct visualization of the pelvic cavity, and biopsy of any lesions can confirm the diagnosis. This method is the most accurate and is recommended when clinical suspicion for endometriosis is high. Option A is incorrect because while transvaginal ultrasound can help identify endometriomas, chocolate cysts, it is not definitive for diagnosing endometriosis. Option C is incorrect because MRI can provide useful information about the extent of endometriosis, especially for deeper lesions, but it is not the gold standard for diagnosis. Option D is incorrect because a hysterosalpingogram HSG is used to assess the patency of the fallopian tubes and is not used to diagnose endometriosis. Relevant guidelines. According to the American Society for Reproductive Medicine, laparoscopy remains the gold standard for diagnosing endometriosis, particularly in cases of infertility or unexplained chronic pelvic pain. Question 22. Neonatal nursing. Respiratory distress syndrome. 30-week preterm infant is admitted to the neonatal intensive care unit NICU with signs of respiratory distress shortly after birth. The baby is tachypneic, has nasal flaring, and exhibits intercostal retractions. Chest X-ray shows ground glass opacities and decreased lung volume. What is the most likely diagnosis and what is the best management approach? Neonate. A. Transient tachypnea of the newborn. TTA is supportive care with oxygen supplementation. B. Respiratory distress syndrome or DA. Administration of surfactant and mechanical ventilation. C. Meconium aspiration syndrome. Mass endotracheal suctioning and supportive care. D. Pneumothorax. Immediate chest tube insertion and monitoring. Answer. B. Respiratory distress syndrome. RDs. Administration of surfactant and mechanical ventilation. Explanation. The signs of tachypnea, nasal flaring, intercostal retractions, and the chest X-ray findings of ground glass opacities are characteristic of respiratory distress syndrome (RDS), a preterm infant. RDS is caused by a deficiency of surfactant in the lungs, which leads to alveolar collapse. The most appropriate treatment is the administration of surfactant and possibly mechanical ventilation to support respiratory function. Option A is incorrect because TTN is more common in term or near-term infants and is usually self-limited. The X-ray findings in this case are not consistent with TTN. Option C is incorrect because mass typically occurs in post-term infants who pass meconium before or during delivery, causing airway obstruction, but it is not associated with the chest X-ray findings described in this case. Option D is incorrect because A pneumothorax would present with asymmetric chest expansion and absent breath sounds, which is not indicated in this case. Relevant guidelines. According to the surfactant therapy and mechanical ventilation are key components in the management of respiratory distress syndrome in preterm infants with the goal of improving oxygenation and preventing further lung injury. Question 23. Obstetric nursing. Preeclampsia, 32-week pregnant woman presents with elevated blood pressure, BP of 160-100 mmHg, proteinuria and edema. She complains of severe headaches and visual disturbances. Laboratory tests show elevated liver enzymes and thrombocytopenia. What is the most likely diagnosis and what is the first priority in management? A. Gestational hypertension. Initiate antihypertensive therapy and monitor BP. B. Preeclampsia with severe features and manage with antihypertensive therapy, magnesium sulfate, and preparation for delivery. C. Chronic hypertension. Increase the patient's antihypertensive medications. D. HELP syndrome. Immediate cesarean section and blood product administration. Answer: B. Preeclampsia with severe features and manage with antihypertensive therapy, magnesium sulfate, and preparation for delivery. Explanation: this patient's presentation with severe hypertension, proteinuria, headaches, visual disturbances, elevated liver enzymes, and thrombocytopenia is indicative of preeclampsia with severe features, which requires immediate management. The goal is to control blood pressure, prevent seizures with magnesium sulfate, prepare for possible delivery, as this is the definitive treatment for preeclampsia. Option A is incorrect because gestational hypertension does not present with proteinuria, elevated liver enzymes, or thrombocytopenia, which are all characteristic of preeclampsia. Option C is incorrect because chronic hypertension would not typically present with the severe features of preeclampsia or the laboratory abnormalities seen here. Option D is incorrect because HELP syndrome, hemolysis, elevated liver enzymes, low platelets is complication of preeclampsia, but immediate cesarean section is not the first step in management unless the maternal or fetal condition dictates urgent delivery. Relevant guidelines. According to COB, preeclampsia with severe features should be managed with antihypertensive medications, magnesium sulfate for seizure prevention and delivery as it is safe for the mother and fetus. Question 24. Gynecologic nursing. Ovarian cysts. 25-year-old woman presents with acute lower abdominal pain and nausea. She has history of irregular periods and has been trying to conceive for the past year without success. Pelvic ultrasound reveals simple ovarian cyst measuring 4 centimeters on the right ovary. What is the most appropriate management for this patient? A. Immediate laparoscopic surgery to remove the cyst. B. Observation with repeat ultrasound in 6-8 weeks. C. Prescribe oral contraceptives to suppress the cyst. D. Begin fertility treatment to increase the chances of conception. Answer: B. Observation with repeat ultrasound in 6-8 weeks. Explanation: most simple ovarian cysts, particularly functional cysts such as follicular or luteal cysts in women of reproductive age, resolve spontaneously without the need for surgery. The most appropriate management is observation with a follow-up ultrasound in 6-8 weeks to monitor for any changes. Option A is incorrect because surgery is only necessary if the cyst causes symptoms that do not resolve, or if there are concerns about rupture or torsion. Option C is incorrect because oral contraceptives may prevent the formation of future cysts but are not necessary for an existing simple cyst. Option D is incorrect because fertility treatment is not indicated until the factors such as ovulatory dysfunction are assessed and confirmed. Relevant guidelines. According to ACOG, simple ovarian cysts in women of reproductive age can typically be managed with observation and follow-up. Surgical intervention is considered if the cysts persist or cause complications. Question 25. Obstetric nursing. Preterm labor. 30-year-old pregnant woman at 32 weeks gestation presents with lower abdominal cramping, back pain, and increased vaginal discharge. She has no history of preterm labor. Upon examination, her cervix is found to be 1 centimeter dilated and 50% effaced. What is the most appropriate management for this patient? A. Administer magnesium sulfate for neuroprotection of the fetus. B. Initiate tocolytics to stop contractions and prevent preterm delivery. C. Administer betamethasone for fetal lung maturation. D. Admit for observation and bed rest. Answer: C. Administer betamethasone for fetal lung maturation. Explanation: this patient is presenting with symptoms consistent with preterm labor. The The most important intervention at this stage is the administration of betamethasone, a corticosteroid, to enhance fetal lung maturation and reduce the risk of respiratory distress syndrome (RDS) in the event of preterm delivery. Option A is incorrect because while magnesium sulfate can be used for neuroprotection in extremely preterm infants 32 weeks, this patient is 32 weeks gestation, which is considered the threshold for steroid administration. Option B is incorrect because tocolytics medications to stop contractions may be considered for patients with preterm labor, but the priority is betamethasone administration to mature the fetal lungs. Option D is incorrect because bed rest alone is not effective in preventing preterm birth, and steroid administration is a higher priority. Relevant guidelines, according to COG, betamethasone should be administered to patients at risk of preterm birth between 24 and 34 weeks gestation to improve fetal lung development. Question 26. Pediatric nursing. Asthma management. 6-year-old child with asthma presents with frequent coughing, wheezing, and difficulty breathing at night. The child uses short-acting beta-agonist inhaler several times a week for symptom relief. The child is diagnosed with persistent asthma. What is the most appropriate pharmacologic treatment for this child? A. Leukotriene receptor antagonist, e.g. montelukast. B. Inhaled corticosteroids, X. C. Long-acting beta-agonist, LABA alone. D. Systemic corticosteroids for acute exacerbations. Answer: B. Inhaled corticosteroids, X. Explanation: for persistent asthma, the most appropriate treatment is inhaled corticosteroids. ICs are the most effective long-term control medication for reducing airway inflammation, preventing asthma symptoms, and reducing the frequency of exacerbations. Option A is incorrect because leukotriene receptor antagonists are often used as adjuncts to ICs, not as first-line treatment. Option C is incorrect because long-acting beta-agonists LABA should not be used alone in asthma management due to the risk of severe exacerbations. They should always be combined with ICs. Option D is incorrect because systemic corticosteroids are used in the short term for acute exacerbations, but they are not part of long-term management. Relevant guidelines, according to the National Asthma Education and Prevention Program, inhaled corticosteroids are the cornerstone of therapy for persistent asthma and should be used in combination with bronchodilators as needed. Question 27. Cardiovascular nursing. Hypertension management. 55-year-old male with history of hypertension presents for routine checkup. His blood pressure is consistently elevated at 106/95 mmHg during 3 separate visits. He is asymptomatic and denies any history of cardiovascular events. What is the next best step in managing this patient? A. Start ACE inhibitors and beta blockers for blood pressure control. B. Recommend lifestyle changes and initiate thiazide diuretics if BP remains elevated. C. Initiate calcium channel blockers and diuretics. D. Begin statin therapy for primary prevention of cardiovascular disease. Answer: B. Recommend lifestyle changes and initiate thiazide diuretics if BP remains elevated. Explanation: for a patient with hypertension defined as E equals 104/9 mmHg, the first step in management is recommending lifestyle changes, e.g. weight loss, exercise, sodium reduction, etc. If blood pressure remains elevated after lifestyle modifications, the next step is typically initiated. Thiazide diuretics, which are effective in lowering BP and are often the first-line medication in uncomplicated hypertension. Option A is incorrect because while ACE inhibitors and beta blockers may be used in certain conditions, thiazide diuretics are typically preferred for initial management. Option C is incorrect because calcium channel blockers are used as an alternative to thiazide diuretics, but they are not typically first line. Option D is incorrect because while statins may be used in patients with history of cardiovascular disease, they are not the first step in managing primary hypertension. Relevant guidelines, according to JNC8, lifestyle changes and thiazide diuretics are recommended as the initial approach to managing stage 1 hypertension. Question 20. Neurological nursing. Stroke management. 70-year-old male with history of hypertension and hyperlipidemia presents with sudden onset of left-sided weakness, difficulty speaking, and facial droop. Is 3 hours from symptom onset. What is the most appropriate next step in his management? A. Administer intravenous tissue plasminogen activator, EPA. B. Obtain CT scan of the brain to rule out hemorrhagic stroke. C. Start antiplatelet therapy immediately and admit for observation. D. Initiate anticoagulation therapy for potential atrial fibrillation. Answer: B. Obtain an EK of the brain to rule out hemorrhagic stroke. Explanation. This patient is presenting with symptoms suggestive of an ischemic stroke, sudden onset of weakness, speech difficulty, and facial droop. The first step in management is obtaining an EK of the brain to rule out hemorrhagic stroke. Only after hemorrhagic stroke is ruled out can intravenous EPA be considered for an ischemic stroke within the treatment window, typically within 4.5 hours of symptom onset. Option A is incorrect because TPA should not be administered until hemorrhagic stroke is ruled out with ACAN. Option C is incorrect because antiplatelet therapy is not the immediate treatment for an acute ischemic stroke. The priority is CT imaging. Option D is incorrect because anticoagulation therapy is used for atrial fibrillation-related strokes, but in this case, the acute management focuses on imaging to rule out hemorrhage. Relevant guidelines. According to the American Heart Association, CT imaging is essential for differentiating between ischemic and hemorrhagic stroke before the administration of TPA. Question 29. Infectious disease nursing. Tuberculosis, 40-year-old woman with history of diabetes mellitus, presents with chronic cough, night sweats, fever, and weight loss. Chest X-ray shows upper lobe infiltrates. Her tuberculin skin test TSD is positive, and sputum cultures grow Mycobacterium tuberculosis. What is the most appropriate treatment regimen for this patient? A single drug therapy with isoniazid. B. Combination therapy with isoniazid, rifampin, ethambutol, and pyrazinamide. C. Dual therapy with rifampin and isoniazid. D. Monotherapy with rifampin for 6 months. Answer. B. Combination therapy with isoniazid, rifampin, ethambutol, and pyrazinamide. Explanation. For active tuberculosis TB, the standard treatment involves combination therapy with isoniazid, rifampin, ethambutol, and pyrazinamide for an initial phase, followed by continuation therapy with isoniazid and rifampin for a total duration of 6 months. This combination is used to prevent resistance and effectively eradicate infection. Option A is incorrect because isoniazid alone is not sufficient for treating active TB due to the risk of resistance. Option C is incorrect because dual therapy with rifampin and isoniazid is not recommended for initial treatment as it does not cover all potential TB bacteria. Option D is incorrect because rifampin alone is not effective in treating active TB without other medications. Relevant guidelines. According to the CDC, the initial treatment for active TB involves a 4-drug regimen of isoniazid, rifampin, ethambutol, and pyrazinamide, followed by continued therapy with isoniazid and rifampin. Question 30. Endocrine nursing. Diabetes management. 60-year-old male with 10-year history of type 2 diabetes mellitus, presents with polyuria, polydipsia, and blurred vision. His most recent fasting blood glucose is 250 mgl and his AC is 9.2%. What is the most appropriate next step in the management of this patient? A. Increase the dose of metformin. B. Start insulin therapy. C. Initiate sulfonylureas. D. Recommend lifestyle modifications and continue current treatment. Answer. B. Start insulin therapy. Explanation. This patient has poorly controlled type 2 diabetes as evidenced by an elevated fasting blood glucose and an AC of 9.2%, which is above the target of 7% for most diabetic patients. The first step for a patient with uncontrolled diabetes and symptoms such as polyuria, polydipsia, and blurred vision is to initiate insulin therapy to quickly achieve better glucose control. Option there is incorrect because increasing the dose of metformin may be necessary in some cases, but it will not provide the same immediate effect as insulin therapy in patients with significant hypoglycemia. Option C is incorrect because sulfonylureas may be added for blood glucose control, but they are typically not started in patients with such high blood glucose levels. Option D is incorrect because lifestyle modifications alone are insufficient to bring blood glucose levels under control in patients with poor control of their diabetes. Relevant guidelines. According to the American Diabetes Association, ADA, patients with uncontrolled diabetes may require insulin therapy when oral medications fail to adequately control blood glucose.